Greetings of the day. The module on antiretroviral therapy is intended for the doctors working at ART Center. By the end of this module, participants would be able to provide ARVs to the patients presenting at ART Center according to the consolidated guidelines, monitor patients on ART following the composed protocol, describe antiretroviral drugs, their classification, mechanism of action and resistance, and adverse effects of commonly used ARVs, prescribe ARVs in adults, adolescents, children, and pregnant and lactating females, prescribe ARVs in special situations like renal failure. We shall be discussing about the goals of starting ART, then classification of antiretroviral drugs. We will be discussing about drug-drug interactions, adverse effects, and management of those adverse effects. Then we will be discussing when to start ARV, what to start in ARV, and how to monitor the patients who are on ART, monitoring of response of ART, resistance mechanism, and selecting second and third line ART. Patient presenting to ART center can be treatment naive or treatment experienced. By definition, a person with HIV who has never taken antiretrovirus treatment or drugs is known as treatment naive, while a person with HIV who is currently taking ARV or has previously taken antiretroviral drugs is known as treatment experienced. The introduction of antiretroviral drugs has reduced the morbidity and mortality at all the stages of HIV. It has also reduced the risk of transmission of HIV from one person to another. The following are the key treatment goals of starting ART. Number 1, maximal and durable suppressed plasma HIV RNA levels, which further reduces the risk of development of drug-resistant mutants and restores and preserves the immunological function, improves the CD4 count, which reduces the risk of acquiring opportunistic infections, hence improving the morbidity and mortality. Then reduction of HIV-associated morbidity and prolonging the duration and quality of survival. Prevention of HIV transmission, and at the time of pregnancy, the viral load must be suppressed at the time of delivery. The ARVs have also reduced the immunological reactivation and inflammation, which are thought to increase the risk of cardiovascular diseases and other diseases in people living with HIV. After initiation of effective ART, viral load reduction to below the limits of assay detection usually occurs in first 12 to 24 weeks of therapy. The predictors of virological success include low baseline viremia, high potency of ARV regimen, tolerability of regimen, convenience of regimen, and excellent adherence to the regimen. Antiretroviral drugs are classified according to the site of their action, and they are broadly divided into 8 groups. Number 1 is nucleoside reverse transcriptase inhibitors or NRTIs. Non-nucleoside reverse transcriptase inhibitors or NNRTIs, protease inhibitors, PIs, integrase inhibitors or INSTIs, fusion inhibitors, CCR5 antagonists, CD4 post attachment inhibitors, and GP120 attachment inhibitors. This slide shows the HIV virus life cycle in a host cell, starting from the viral entry into the cell and the site of action of different ARVs. The fusion inhibitors and CCR5 co-receptor antagonists inhibits the entry of virus into the cell. NRTIs and NNRTIs inhibit the transcription by inhibiting the reverse transcriptase enzyme. Integration is inhibited by INSTIs, and protease inhibitors work on protease enzyme and inhibits the cleavage of viral DNA. So we shall be discussing the commonly available ARVs in Pakistan and their mechanism of action, mechanism of resistance, side effects, and drug-drug interactions. NRTIs was the first class of antiretroviral drugs introduced to inhibit HIV and particularly HIV infection, and with the introduction of these drugs, significant reduction in mortality and morbidity was noted. This class of drugs form the core component or backbone of currently available first-line ARV regimen. Total 9 members were included in this class. However, Pakistan uh, has only abacavir, zidovudine, tenofovir, and lamivudine available. In this region, two of the drugs from the class, adenosine and stomidine, have been withdrawn due to their severe adverse effects related to mitochondrial toxicity. These drugs, as the name indicate, inhibits the reverse transcription enzyme in HIV virus. These drugs are available as a prodrugs, and to inhibit the reverse transcriptase enzyme, they first must be phosphorylated by intracellular kinases into their active fat phosphate form. Along with inhibiting the HIV virus reverse transcriptase, these drugs also inhibit some of the normal cellular DNA polymerases in a host cell, and notably mitochondrial DNA polymerase is inhibited to much lesser extent. However, it is inhibited, and this uh, leads to the drug-specific side effects like hyperlactatemia, lactic acidosis, hepatic steatosis, peripheral neuropathies, myopathy, and lipomatosis. However, the association of different drugs in reduction of mitochondrial DNA polymerase is different, and lamivudine, emtricitabine, abacavir, and tenofovir are least likely to be associated with adverse drug effects resulting from mitochondrial dysfunction. The most commonly associated drugs with these side effects are adenosine and stomidine. NRTIs interrupt the HIV replication cycle through competitive inhibition of HIV reverse transcriptase enzyme and results in termination of the proviral DNA chain. Reverse transcriptase is an HIV-specific DNA polymerase which allows HIV RNA to be transcribed into single-stranded and ultimately into double-stranded proviral DNA before incorporation into the host cell genome. This proviral DNA chain elongation is necessary before the genome is incorporated into the host cell, and this occurs by the addition of purine and pyrimidine nucleoside to 3' end of the growing chain. NRTI are structurally similar to these DNA nucleoside bases, and they become incorporated into proviral DNA chain and result in termination of proviral DNA formation, thus inhibiting the chain elongation and inhibiting the HIV replication cycle at this level. The mechanism of resistance to this drug occurs through two methods. Number one is either impaired incorporation into the proviral DNA chain of these NRTIs or removal from the proviral DNA chain of these NRTIs. Here you can see the incorporation of NRTIs are blocked, and hence the chain does not terminate over here and keeps elongating. Removal of these NRTIs from proviral DNA chain is associated with TAME's mutation, and it causes the conformational changes in reverse transcriptase domain that allows the addition of ATP or pyrophosphate to the end. This placement causes a break in proviral DNA and NRTI bond, and it enables the continued elongation of proviral DNA strand, hence making the drug resistance in this virus. Lamivudine is a cytosine analog with activity against HIV and hepatitis B virus. The drug is contraindicated in cases of known hypersensitivity. Drugs should be used with caution in patients with lactic acidosis and hepatic acidosis. Commonly noted adverse effects are headache, nausea, fatigue, neutropenia, and less frequently associated adverse effects include lactic acidosis, hepatic acidosis, peripheral neuropathies, and pancreatitis, which are due to inhibition of mitochondrial DNA polymerase of host cell. Okay. Since the drug has activity against hepatitis B and HIV both, so care should be taken when discontinuing lamivudine in patients who are co-infected with hepatitis B virus, because withdrawing of this drug will result in rebound of hepatitis B virus and worsening of hepatitis infection. Abacavir is synthetic guanosine analog. The drug is contraindicated if there is a prior hypersensitivity reaction to abacavir, if HLA-B5701 allele mutation is present, if there is moderate to severe hepatic impairment is present, and the cautious use is recommended in patients with lactic acidosis and severe hepatomegaly with steatosis. Commonly observed adverse effects include fetal hypersensitivity reaction (HSR), which manifests as fever, abdominal pain, flu-like symptoms, and rash. The hypersensitivity reaction is noted within 2 weeks of starting abacavir usually, and it requires the discontinuation of the drug. These symptoms resolve usually in 3 to 5 days of stopping abacavir, and if the drug is not stopped, this may turn into the fatal life-threatening hypersensitivity reaction. So this syndrome has been linked to the presence of HLA-B5701 allele. International guidelines recommend to test for this allele at the bedside or while planning to start abacavir, but this genotyping testing is not available in Pakistan. So we recommend the patient, we tell them the signs and symptoms of this hypersensitivity reaction and advise them to vigilantly monitor for these symptoms and return back to the ART center immediately if they develop any of these symptoms. And we also vigilantly monitor these patients, especially during the first 2 weeks of starting abacavir. If any of the signs and symptoms are developed in a patient or there is a suspicion of abacavir, we recommend to stop this drug immediately and never to reintroduce abacavir if hypersensitivity reaction is suspected. Then, the use of abacavir with ribavirin or ganciclovir can increase the risk of mitochondrial, hepatic, and pancreatic toxicities. And there are a few studies which have seen the association of abacavir with increased risk of cardiovascular disease. Tenofovir is a nucleotide adenosine 5-monophosphate derivative, and it's available in 2 forms: tenofovir disoproxil fumarate and tenofovir alafenamide fumarate, or TEF. There is a difference between 2 forms based on the renal toxicity. TDF is associated more with deranged renal functions and decreased mineral bone density as compared to TDF. TDF has a beneficial effect on plasma cholesterol levels, while this beneficial effect is missing with TAF. Both drugs are equally effective in suppressing the viral load and for hepatitis B virus treatment. There are certain things which should be checked before initiating these drugs, and these include test of hepatitis B virus and HIV-1 infection, assessment of serum creatinine, estimated creatinine clearance, urinary glucose, and urinary protein in all the patients, and especially those who are at high risk of developing TDF-induced nephrotoxicities. In patients who are already suffering with a chronic kidney disease, also assess for serum phosphorus levels. X-ray and bone density assessment may be considered in patients who are suspected to have bone mineralization disorders. The drug is contraindicated in renal insufficiency. Common adverse effects which have been noted with TDF include nephrotoxicity, and the risk factors for developing this nephrotoxicity are older age, already present renal diseases, low BMI, untreated diabetes mellitus, hypertension, and concomitant use of other nephrotoxic drugs or boosted PIs. Another side effect which has been seen in patients who were on TDF is reduced bone mineral density, especially in children. X-ray, DEXA scan, and supplements can be used with regular growth monitoring chart to deal with this adverse effect. Then, like other NRTIs, lactic acidosis, steatosis, and peripheral neuropathy has been associated with the use, although these are less common. And with abrupt withdrawal of this drug, although this is not considered an adverse effect, but it has been noted that abrupt withdrawal of this drug has resulted in flare in hepatitis B virus and worsening of hepatitis. Zidovudine was the very first antiretroviral medication which was introduced and used for the treatment of HIV, and it clearly demonstrated the reduction in morbidity and mortality associated with the disease. The drug is a thymidine analog which interferes with HIV viral RNA-dependent DNA polymerase and results in inhibition of viral replication and nucleoside reverse transcriptase inhibition. The drug has been used for the prevention of maternal to fetal HIV transmission at the time of delivery, and it has found to reduce the perinatal transmission. However, IV zidovudine form is not available in Pakistan. Before starting zidovudine or after starting zidovudine, CBC should be monitored with differential count, and in a patient who have poor bone marrow reserve, CBC monitoring should be done on more frequent basis. LFT should be seen and serum creatinine should also be seen. HIV viral load and CD4 count should be monitored. The drug is contraindicated when potentially life-threatening hypersensitivity to zidovudine or any component of the formulation has been noticed. Commonly noted adverse effects include anemia, which is usually macrocytic, and the risk factors for developing this anemia include anemia present at the baseline or at the time of starting this zidovudine-based regimen, and CD4 count less than 200 and presence of neutropenia. Then lactic acidosis and steatosis has also been associated with zidovudine, and the risk factors of developing these adverse effects include prolonged exposure to the drug and obesity. Non-nucleoside reverse transcriptase inhibitors or NNRTIs were first introduced in 1996 with the introduction of nevirapine as the first drug in the group. These drugs are potently active against HIV-1. However, HIV-2 virus is intrinsically resistant to these drugs, and hence it is not recommended to include NNRTIs when designing regimen for HIV-2 viruses. Efavirenz in particular has the most significant inhibition of viral infectivity among the group. Previously, efavirenz was used as a first-line regimen with TDF and 3TC. However, it's phasing out now. The members are divided into first generation and second generation. First generation NNRTIs include dalavudine, efavirenz, and nevirapine, while Atromyrene and ribavirin are included in second generation NNRTI group. Pakistan has the availability of efavirenz and nevirapine only. And unlike NRTIs, they do not need phosphorylation to become active. These drugs have a long half-life, almost 25 to 55 hours. NNRTIs also inhibit the reverse transcriptase enzyme, but their mechanism of action is different from NRTIs. They non-competitively inhibit the reverse transcriptase enzyme. The drug is found at the hydrophobic pocket, which is distant from the active site of reverse transcriptase and results in blocking of DNA polymerization, hence resulting in the termination of provided DNA chain. However, in a resistant or mutant virus, this ability of NNRTI to bind to this pocket is inhibited. Hence, NNRTI cannot bind to this site and chain polymerization continues. Now, to note here that the barrier to HIV-1 resistance is low for NNRTIs, and single point mutations and reverse transcriptase can inactivate all the members of this class with the exception of atromyrene. It means that if a single point mutation is present in reverse transcriptase for NNRTIs, there will be a cross resistance between the members of same class. Efavirenz and nevirapine are the only available drugs in Pakistan from this class of ARV. Efavirenz was once used as a core drug in first-line ARV regimen. However, it is no more recommended to be used as first-line therapy due to availability of better antiretrovirals. The drug is contraindicated if any hypersensitivity reaction has been reported, and this includes Stevens-Johnson syndrome, erythema multiforme, or toxic skin eruptions. The commonly noted adverse effects include CNS toxicity. Patients might present with peripheral neuropathy, increased forgetfulness, or nightmares. Rash, hepatotoxicity, and dyslipidemias are also the commonly noted adverse effects with this drug. Nevirapine is currently being phased out in adults and also in children, except it is used in young infants who are on prophylaxis. The contraindications of drug include hypersensitivity, child class B and C hepatic insufficiency. Use with caution is recommended in patients with lactic acidosis and hepatic acidosis. Commonly observed adverse effects of NVP include rash, can occur in 50% of the cases, and this includes Stevens-Johnson syndrome. Symptomatic hepatitis, including fatty hepatic necrosis, has also been reported. Hepatitis are specifically associated with ARV-naive female patients with pre-NVP CD4 count of more than 250 cells per cubic millimeter, and in ARV-naive male patients with pre-NVP CD4 count of more than 400 cells per cubic millimeter. And underlying hepatic disease, hepatitis B and hepatitis C virus co-infection, and with concomitant use of hepatotoxic drugs. Hepatic injury may progress despite treatment discontinuation in this condition. Monitoring of LFTs is recommended, and if hepatitis develops, it is recommended not to restart NVP and replace NVP with any other drug. We shall now discuss the management of common adverse effects which have been associated with NRTIs and NRTIs which are available in Pakistan. In next slide. If a patient presents with hypersensitivity reaction and on examination you find a rash and history suggests a fever, nausea, vomiting, and the regimen contains abacavir, then the culprit drug to be considered is abacavir, and hypersensitivity reaction should be considered in these patients. Screening for other viral infectious illnesses should be done. At the time of the starting of abacavir, early and regular follow-up of patient with warning clinical sign card to the patient should be handed over, and patient should be advised to report back to ART center as soon as he or she develops symptoms which are suggestive of hypersensitivity reaction. Antihistamines can be tried, and if a hypersensitivity reaction is suspected, abacavis should be switched with other antiretrovirals. If lactic acidosis and hepatic toxicities are associated with abacavir, uh, again, drugs should be switched with other antiretrovirals. If a patient presents with drug eruptions, uh, these drug eruptions can be mild to severe, like Stevens-Johnson syndrome or toxic epidermal necrolysis. One should review the regimen for the presence of NBP or efavirenz. If these are present, then these might be the culprit drug, however. In mild cases, only symptomatic care is indicated. If a patient is taking trimethoprim sulfamethoxazole simultaneously, then this drug should be stopped first and patient should be observed for the improvement of these rashes. Rashes due to efavirenz often stops spontaneously after 3 to 5 days without a need to change to ART. But if these persist, then ART should be changed. If rash is moderate, non-progressing, and without any mucosal involvement or systemic signs and symptoms, consideration should be given to a single NNRTI substitution, that is, from NBP to efavirenz. In moderate and severe cases, discontinuation of ART is recommended, supportive treatment is recommended, and after resolution, ART should be resumed with INSTI-based regimen rather than reintroducing of these NNRT. If a patient presents with anemia and neutropenia and zidovudine is a part of the currently prescribed regimen, then the most likely culprit is zidovudine. In cases of severe anemia, that is hemoglobin of less than 10 or ANC count of less than 750, replacement with an ARV with minimal or no bone marrow toxicity like tenofovir or abacavir is indicated. All NRTIs can cause lactic acidosis, dyslipidemias, lipodystrophies, and hepatitis. So drugs should be reviewed if a patient presents in any of these. And in case of lactic acidosis, ART should be discontinued and supportive therapy should be started. And after resolution of lactic acidosis, ART should be resumed with TDF-based regimen. Dyslipidemias are particularly associated with efavirenz, so consideration should be given to replace this drug with other ART. In case of lipodystrophies, early replacement of suspected ARV drug with switching to tenofovir or zidovudine should be considered. Diadermicine and strividine were most likely associated with these lipodystrophies and they have been withdrawn from the community due to these side effects. Hepatitis is particularly associated with nevirapine, and if ALT is found to be more than 5 times the basal level, discontinuation of ART and monitoring is recommended. Once the hepatitis is resolved, ART should be restarted with replacing the NBP with efavirenz or any other. If a patient presents with neuropsychiatric signs symptoms, the most commonly associated drugs are efavirenz or dolutegravir. The neuropsychiatric signs and symptoms are usually self-limited, and most of the time there is no need to switch ART or discontinue ART. Only the assurance, early follow-up can help in improved tolerability to these signs and symptoms. However, if these signs and symptoms become intolerable to the patient, then the drug should be replaced with DTG if patient is on efavirenz, or efavirenz if patient is on DTG. Single substitution is recommended without cessation of ART. DTG has been found associated with insomnia, and if it is the case, then DTG should be taken in the morning. Renal toxicity is associated with TTF, and if it is present, then the substitution should be considered with either zidovudine or abacavir. Protease inhibitors were first introduced in 1995 and are now the integral part of HIV treatment. These are effective components of second-line and third-line or salvage ARV regimens in adults who are failing first-line therapy and initial regimen in children. They have activity against both HIV-1 and HIV-2 viruses. Total 8 drugs are included in this class. In Pakistan, atazanavir and lopinavir, boosted with ritonavir, are available. Ritonavir is a potent inhibitor of CYP3A4 metabolism enzyme, and this property has been used to increase the plasma drug levels of other PIs by co-administering subtherapeutic doses of ritonavir, and this is known as boosting. So whenever atazanavir and lopinavir are present with the subtherapeutic doses of ritonavir, they are called as boosted atazanavir or boosted lopinavir. These drugs inhibit HIV protease enzyme as a competitive inhibitor. They directly bind to HIV protein and prevent subsequent cleavage of polypeptides. These inhibitors have a higher genetic barrier to resistance when compared to NNRTIs or integrase inhibitors. Multiple mutations are required to substantially lose the antiviral activity. Resistance usually results from mutations both inside and outside the active protease domain, and it typically occurs through the development of one or more major mutations which produce conformational changes in protease binding site, followed by secondary compensatory mutations that improve enzymatic activity and, in some cases, viral fitness. Number of mutations rather than site of mutation is more important, especially in the boosted regimen. Lopinavir, ritonavir are contraindicated if any hypersensitivity has been reported with either of the drugs. Concomitant administration of CYP3A4 enzyme inducers or major subset of this enzyme is also contraindicated. There is a list of drugs which should not be administered with the lopinavir and ritonavir, and important drugs include alpha-1 receptor agonist and rifampicin and voriconazole, because most of our patients who are on ARV are also requiring ATT for their tuberculosis treatment. So, care should be taken while administrating these drugs with lopinavir and ritonavir. Atazanavir is contraindicated if any hypersensitivity has been demonstrated previously. In a patients who are treatment experienced and are with ESRD and receiving hemodialysis, in patients who have severe hepatic impairment and co-administration with drugs who are highly dependent on these enzymes for their care. As a practice and every may between lower exposure of efficacy of ethanol. There is a list of drugs which atazanavir may elevate the plasma concentrations of, and these should be reviewed while administering these drugs with atazanavir. The list of these drugs can be found on website or on Medscape easily. Common adverse effects reported with atazanavir and ritonavir are ECG abnormality, indirect capillary anemia, and nephrolithiasis. And common adverse effects associated with lopinavir ritonavir are GI symptoms. However, ECG abnormalities, which includes PR and QT prolongation, especially in patients who have underlying cardiac disease, electrolyte abnormalities, congenital long QT syndrome, or who are using concomitantly the QT prolonging drugs have been noted. Lipid abnormalities, pancreatitis, hepatotoxicity, risk of fat redistribution, hemolytic anemias, Hyperglycemias and hyperlipidemia, especially when used with other ARVs, has also been reported. And caution must be taken while introducing lopinavir ritonavir in patients with these abnormalities or risk factors for these abnormalities. Okay. The solution which is used in newborns contain 42.4% alcohol in propylene glycol. Now, what happens in newborn babies or premature babies? Uh, they have decreased ability to eliminate propylene glycol, and this increases the risk of toxicities, and serious cardiac, renal, and breathing problems have been reported when the drug has been used in newborns or premature babies. The post-marketing life-threatening cases of cardiac toxicity, which includes complete AV block, bradycardia, cardiomyopathy, lactic acidosis, acute renal failure, CNS depression, and respiratory complications leading to death, have also been reported, predominantly in preterm newborns. The oral solution should be avoided in premature babies until they are 42 weeks old, that is 14 days after their due date, or in full-term babies younger than 14 days of age, unless a healthcare professional believes that the benefit of using lopinavir ritonavir oral solution to treat HIV infection immediately after birth outweighs the potential risk. In such situations, FDA strongly recommends monitoring for increase in serum osmolality, serum creatinine, and other signs of toxicity. Integrase inhibitors or INSTIs have a crystal structure, and they were first described in 1994, and they led to the identification of novel inhibitors. The drugs work at integrase enzyme and inhibits it. Drugs are now used as a first-line regimen in most of the countries. Available drugs are bictegravir, dolutegravir, raltegravir, and cabotegravir. Pakistan has dolutegravir and REL as available drug. However, REL is phasing out from Pakistan, and it's usually unavailable. These agents competitively inhibit the strand transfer reaction by binding the metallic ions in active site, and these drugs have high genetic barrier for resistance except for RAL, which becomes resistant very early. But the discussion of this mechanism of resistance and beyond the scope of this presentation. Dolutegravir is a preferred drug and is used as a first-line regimen in treatment-naive patients. It was first approved by FDA in August 2013 for the treatment of HIV-1 infection in combination with other ARV drugs in adults and in children who are equal to or more than 12 years of age and who have a weight of at least 40 kg. The drug is contraindicated if any hypersensitivity has been reported, and also the co-administration of drug with dofetilide is contraindicated due to the potential for increased dofetilide plasma concentration and risk of serious life-threatening events. Dolutegravir in pregnancy was previously thought to cause neural defects, but the new literature, especially the TESPO study, reports that the risk of neural defects is less than it was once thought, and hence the drug is now not contraindicated in pregnancy. Commonly noted adverse effects of dolutegravir include mild to moderate nausea, headache, diarrhea, rising creatinine, psychiatric symptoms, especially insomnia, in more than 60 years of female, and rapid weight gain. Raltegravir has a low genetic barrier for resistance, and it is now recommended either as a first-line therapy in pediatric population or as an alternate medication in adults. The drug has no contraindication. However, cautious use is recommended in autoimmune diseases and co-administration with drugs which are known to cause myopathy and leptomyopathy. Commonly observed adverse effects include asymptoticability, nasopharyngitis, rash, herpes zoster virus infection, and elevation of AST and AST, and increased triglyceride levels. Elevation creatinine kinase levels, myalgia, and proximal myopathies. Neuropsychiatric side effects which have been associated with Antiretroviral include depression, insomnia, but the precise relationship between drug and effect requires further study. Effect of food should be considered while prescribing these medications. So it should be noted that atazanavir should be given with food and efavirenz should be given without food. Usually the patients presenting with neuropsychiatric symptoms or side effects associated with efavirenz, the advice of taking efavirenz on empty stomach helps in improving these symptoms. Lamivudine, abacavir, tenofovir, zidovudine, nevirapine, lopinavir, ritonavir, dolutegravir, and rentagravir can be taken with or without food, and they are not affected by meals. Dosage modification of certain drugs are required in renal compromise, like lamivudine, tenofovir, zidovudine, lopinavir, ritonavir should be adjusted in patients with compromised renal functions, and in patients who have liver toxicities or who have compromised liver function, abacavir should be modified or adjusted, and lopinavir, ritonavir should be used with caution. Now, when ARV should be started in a patient presenting with HIV, so it has seen that earlier the initiation of ARV resulted in better outcomes. More patients retained in care, there were less loss to follow-up patients, and transmission was reduced. So it is recommended to start ARV treatment in patients on same day after confirmation or within 7 days, provided opportunistic infections have been either ruled out or treated adequately. The recommendation is same for adults, adolescents, children less than 10 years, and pregnant and lactating females. Regardless of WHO staging, clinical status, CD4 count, or comorbidities, the treatment should be started. CD4 count is now not necessary to start ARV regimen. However, this is important to plan the prophylactic antimicrobials to prevent from opportunistic infections, but the therapy should not be delayed in waiting the results for CD4 count. ARV is produced by certain female is used to primarily improve the mother's health and prevent the exposed child from becoming infected. It offers the benefits for preventing the sexual transmission of HIV, as well as the treatment should be started immediately, regardless of CD4 count and the lethal symptoms. After delivery, mothers are recommended to breastfeed their child, and they should be continued ARV. So, at the time of their next pregnancy, they should be virally suppressed. In patients who are returning to care, first step is the assessment of ongoing opportunistic infections and adequate treatment if necessary, and assessment of willingness of a patient to start treatment. However, this assessment should not take too long, and ART should be started as early as possible, provided the other factors have been addressed well. There are certain situations where delay in therapy is recommended, and these include presence of tuberculosis or cryptococcal meningitis as a co-infection or opportunistic infections, mental health disorder, substance abuse, unwillingness of patient to start ARV, and PWIDs who are lost to follow-up and now coming back to the care centers. In patients with mental health disorders and substance abuse, they are usually not ready or they are not organized to understand the benefit of starting ARV. Hence, time should be taken to make sure that these factors have been adequately addressed. In a patient with tuberculous meningitis, the therapy should be started between 4 to 8 weeks of starting ATT. In a patient with tuberculosis but non-meningitic tuberculosis, therapy can be initiated within 2 weeks of therapy depending on their CD4 counts. In cryptococcal meningitis, therapy should be delayed for 4 to 6 weeks after starting antifungal treatment. Otherwise, the IRIS associated with these two conditions is life-threatening and may result in loss of life of a patient. The therapy, in a nutshell, should not be too early in certain situations or should not be too late. In a patient with mental health issues or other reasons for non-adherence or non-compliance or not willing to take ART should only be started when provisions are made for improving compliance. Involvement of a family member or a treatment buddy in case of PWIDs and detoxification should be considered before starting the treatment. There are certain factors which should be assessed before starting ART, and when a patient presents to ART center, basic clinical assessment should be done, and this should include comprehensive history taking and examination regarding WHO clinical staging and screening of opportunistic infections in clinical ground, and then proper documentation. Counseling and education of patient and family should be done before starting ART. Their willingness and acceptance to start treatment and their potential for adherence should also be assessed. Patients should be prepared for ART. Regimen should be selected based on the nutritional status, comorbidities, contraindications, the adverse effects and the tolerance of adverse effects, and pregnancy status in females. HIV status of spouse should be checked, and in case of females, the children should also be checked for HIV status, and proper follow-up should be planned and designed and discussed with the patient and family. Before starting ART, risk assessment for opportunistic infection, especially tuberculosis and cryptococcal meningitis, should be done. On the first visit, all patients should have checked their HIV serology, and confirmation should be done with WHO qualified triple test kit. Hepatitis B surface antigen, hepatitis B surface antibody, and anti-HCVs should be checked to know the status of hepatitis B and C. For checking the syphilis, VDRL or RBR should be done. Random blood glucose level, X-ray chest, Montauk in children, CBC, blood urea nitrogen and creatinine, ALT, urine dipstick testing, CD4 count, and pregnancy tests in female should be performed. STI screening should be done verbally, and cryptococcal antigen should be sent if CD4 count is less than 200. The specific test for sexually transmitted infections other than HIV should be sent if clinically indicated. Non-communicable disease screening should be done, and this includes checking of blood pressure on baseline visit and on every visit, and checking of creatinine and hemoglobin, etc. Patients who are returning to care should be assessed for co-infections and opportunistic infections, including pulmonary and extrapulmonary tuberculosis and cryptococcal diseases, and baseline workup should be repeated. If CD4 count is found to be low or is expected to be low as it advanced HIV, workup related to the specific opportunistic infections which can be present in that WHO stage should be done. For example, for PCP, LDH can be sent, serum cryptococcal antigen should be sent, source studies for Cryptosporidium and Isospora, And site-specific workup to look for extrapulmonary tuberculosis should be done. And eye review can be helpful in finding the opportunistic infections-related retinitis. Willingness of starting ART should be assessed, and if ART is meant to be deferred due to any reason, the assessment on O and opportunistic infection should be done on each visit. Serial CD4 cell counts should also be done, which is recommended for every 6 monthly in patients in whom ART has not been started due to any reason. At the time of starting ART, pregnancy tests should be done in women who are in their childbearing age. Blood pressure measurement should be done. Hemoglobin should be checked if the intention is to start zidovudine-based regimen, and renal functions including urine DR, creatinine, and estimated GFR should be checked if the regimen selected contains tenofovir. Initiation of therapy should not be delayed while waiting for these results. This is the recommended frequency of performing these tests in PLHYP. Here, the tests we have already discussed should be performed at the baseline and only once in a patient. And before starting ART, every patient should be clinically checked and examined, and staging should be done, and TB screening should be done. And every 6 months, CD4 count should be checked. And in patients who are injecting drugs or are on blood transfusions, for example, patients with thalassemia, annually, hepatitis C virus core antibody and hepatitis B surface antigen needs to be checked if they are not previously infected with these and are unvaccinated. In males having sex with male or sexual workers and transgenders, annually, RPR should be done to look for syphilis, and clinical screening for STI should be checked. At the time of initiation of therapy, as we have already discussed, every patient should be checked. Every female patient should be checked for pregnancy test and clinical examination. And we have already discussed that what should we do when we are planning to start EZT and tenofovir. This table has been taken from consolidated guidelines, and further details can be seen in our guide. Certain factors should be considered while selecting the regimen. Fixed dose combination is always preferred. If for some reason fixed dose combination cannot be administered, then minimal pill count based regimen should be selected. Timing should be optimal. Adverse effects should be reviewed with the drugs. Contraindication should be reviewed. Co-infection should be ruled out or seen, and drug-drug interactions should be considered while starting AR. What should be the optimal regimen while starting AR? HIV is treated with a triple regimen. So drugs which are recommended to be selected as a first-line regimen in Pakistan should include 2 NRTIs as a backbone. In adults, this backbone is formed with tenofovir and lamivudine, while in children, this backbone is formed either with abacavir or zidovudine along with lamivudine. With this backbone, the third drugs which should be added in adults is INSTI, which is dolutegravir, and in children, protease inhibitors should be added as a third drug, and this includes lopinavir, ritonavir. So the preferred first-line ARV regimen in adults is TDF, 3TC, and DTG, and in children, it should be either abacavir or zidovudine with lamivudine plus lopinavir, ritonavir. Consolidated table shows the preferred and alternate regimen in different patient population and different groups. Here you can see that adults and adolescents, pregnant and breastfeeding females, and in children who are more than 20 kg of weight, Backbone would be based on lamivudine and tenofovir. Lamivudine should always be included in the regimen. And the third drug to be added is dolutegravir. If for any reason TDF cannot be used, then zidovudine or abacavir can be used instead of TDF. However, lamivudine would be continued and dolutegravir would be continued. Here you can see that other available combinations and recommended combinations all have lamivudine continued, because this drug, even if resistant, has beneficial effects on resistance of other drugs, which we'll be seeing in other slides. While selecting the regimen based on abacavir, this should be considered that abacavir is a weak drug and it has more treatment failure rates as compared to other regimens. In children who are more than 20 kg of weight, the alternate regimen advice is based on abacavir, lamivudine, and dolutegravir. ARVs in children is basically based on age and weight then of children. So in children who are less than 20 kg of weight, preferred regimen should contain backbone of either abacavir or zidovudine plus lamivudine and PI, which is lopinavir ritonavir, should be added as a preferred regimen. The alternate options available are either substitution with efavirenz or nevirapine. Abacavir and zidovudine can be used along with lamivudine. Lamivudine should be continued. Protease inhibitors are preferred in both NPP exposed and unexposed children. They have shown the high genetic barrier for resistance and decreased risk of discontinuation, treatment failure, and deaths. In newborn infants who are less than 5 kg of weight, abacavir or zidovudine along with lamivudine should be used as a backbone, and the third drug used should be lopinavir and ritonavir. The alternate includes either abacavir or zidovudine along with lamivudine and nevirapine. Lopinavir ritonavir solution should be avoided in premature babies, which we have already discussed in detail. In patients who are on hemodialysis, tenofovir is not a good option to start with, so the regimen should be based on abacavir and lamivudine along with efavirenz can be used. The dosage adjustment is required in patients with hemodialysis, and many patients who are on hemodialysis also have the problem of anemia, hence zidovudine, if started, should also be very carefully monitored. Here you can see that in neonates and children, based on their weight band, in their preferred alternative regimen or regimen used in special circumstances, lamivudine backbone was continued everywhere. Now, if a patient who had abacavir in their preferred regimen, this abacavir can be switched with zidovudine, and lopinavir ritonavir can be switched with nevirapine. Or if nevirapine was used, then this can be switched with lopinavir ritonavir. In patients in which abacavir was used initially and lopinavir ritonavir cannot be given, then this drug can be switched either with efavirenz or nevirapine. And if abacavir cannot be given, then this drug can be switched with zidovudine. Similarly, in children who are between 20 to 30 kg of weight, if dolutegravir was the part of initial regimen and it for some reason cannot be continued, then lopinavir ritonavir could be substituted for dolutegravir, or efavirenz can be used. Or if lopinavir ritonavir was not a part of initial regimen, then this can be substituted with substituted. In children who are more than 30 kg of weight, the preferred regimen is as for adults, that is TLD or tenofovir, lamivudine, and dolutegravir. Special circumstances in children where first-line regimen cannot be administered, like anemia and nevirapine toxicity, where zidovudine and nevirapine cannot be used. Regimen can be made with abacavir and lamivudine backbone in the form of dispersible tablets, and third drug can be added according to the weight. If weight is less than 10 kg, then lopinavir, ritonavir in pellets form can be used. If weight is more than 10 kg, efavirenz can be used, and if weight is more than 20 kg, dolutegravir can be used. Similarly, if ATT is being co-administered with ARV, then regimen can be changed as backbone with abacavir and lamivudine will be continued, and lopinavir ritonavir can be used, or zidovudine syrup can be used only if the patient is on rifampicin. Then first-line standard regimen should be resumed. Then efavirenz can be used in the form of sport tablet if the weight is more than 10 kg, or dolutegravir can use if more than 20 kg. However, this is to remember that lopinavir, ritonavir, and dolutegravir should be administered in double dosage. There are certain tests which should be performed after initiation of ARV at the defined interval of time. So, for all the patients who have been started on ARV, viral load and clinical examination and nutrition assessment should be done initially at 3 months after initiation of therapy, and then after every 6 months. The rationale of doing these tests is to monitor the success of the selected ARV regimen and to monitor the side effects associated with ARVs. If the CD4 count was less than 350 at the time of starting ART, then it should be checked every 6 months till the CD4 count becomes 350 for 2 consecutive tests. In case of suspected failure, viral load and HIV testing should be done immediately. If a patient is on AZT-based regimen, then hemoglobin should be checked every 3 months, and in case of TDF, urine, DR, dipstick testing, and creatinine should be checked initially for every 3 months for the first year and then every 6 months. In pregnant females, the viral load should be checked at the time of establishment of pregnancy and then at 36 weeks of gestation. In patients who are thalassemia and require frequent blood product transfusion, hepatitis B and C status, liver function test, kidney function test, thyroid profile, parathyroid function test, and calcium phosphate, parathyroid hormone, especially if a patient is more than 5 years of age, and cardiac assessment should be done every year or as per need. We shall now discuss the recommendations in special circumstances. So, initially, the first-line therapy in Pakistan was efavirenz-based. So, patients who are doing well on efavirenz-based therapy should be considered to be shifted on dolu-based regimen. But at the time of switch, the VL should be suppressed, and if the VL is not suppressed, then second-line ART should be considered. In a patients who are co-infected with hepatitis B virus infection, this should be seen that whether they are newly diagnosed and they don't have any previous exposure to lamivudine or tenofovir, then the HIV regimen should contain these two drugs. And if they have already been exposed to tenofovir for hepatitis B as a monotherapy, tenofovir will be continued in the regimen, but this will not be counted as a core medication for HIV. And regimen should contain 3 new drugs for HIV. Lamivudine will be included in it. Patients who are co-infected with tuberculosis, double dosage of dolutegravir or lopinavir ritonavir should be administered with rifampicin, and efavirenz would be continued on same dose, while atazanavir is not recommended to be used with rifampicin. Children who are less than 20 kg of weight and are co-infected with TB and HIV have been diagnosed together. Preferred regimen is abacavir, lamivudine, and renitrogravir. Triple NRTI regimen based on zidovudine, lamivudine, and abacavir is an alternate to this regimen. Infant diagnosed to have tuberculosis while he was already on preferred regimen, it is recommended to continue the same regimen while ETT is started. If a child is not on first-line regimen at the time of TB diagnosis, then he should be shifted to preferred regimen. Once the TB treatment has been completed, the regimen should immediately be changed back to the first-line ART provided Rentagravir is available in the region. Dolutegravir is preferred over efavirenz because of its high barrier to resistance, low chances of primary resistance, low frequency of neuropsychiatric symptoms associated, which leads to better tolerance, and faster decline of viral load at 29 days as compared to efavirenz, in which the viral load declined in 78 days. Only benefit of efavirenz over dolutegravir comes when rifampicin has to be co-administered. In cases of DTG-based regimen, double dosage is recommended to be administered with rifampicin, while no drug change dosage change is recommended for efavirenz. Both drugs are safe in pregnancy and are available in fixed dose combination. A Vacavir-based regimen is not a preferred alternate option because the backbone is associated with more treatment failures in patients when the viral load was high. This drug should be avoided in patients with high viral load or suspected ischemic heart diseases because there were certain studies which have shown the association of abacavir with increased risk of ischemic heart disease. After starting ART, the follow-up should be planned within 1 to 2 weeks. This will give the reassurance to the patient and he will feel connected and will be more adherent to the medications. Early follow-up will also help in monitoring the side effects, iris reaction if occurring any, and manifestations of opportunistic infections. And it will also give an opportunity for adherence counseling and assessment of adherence. Drug-drug interactions should always be looked in a patient if they are already on certain drugs and ARV is now going to be introduced or vice versa. This should always be remembered that rifampicin is a very strong inducer and it has significant drug-drug interactions with boosted PIs, INSTIs, and nevirapine. If patient is on dolu-based regimen or boosted PIs regimen, try to substitute rifampicin with rifabutin or adjust the doses of DTT and boosted PIs. Also, you can substitute with 3 NRTIs in case of children, as we have already discussed. If the patient is on nevirapine and rifampicin has to be co-administered, then nevirapine should be switched with efavirenz. Efavirenz in abacavir does not need any dose adjustment with rifampicin. Ribavirin and pegylated interferon has significant drug interactions with zidovudine, and it is recommended to substitute zidovudine with tenofovir as the first-line therapy. Estrogen-based hormonal contraception also have interaction with boosted PIs, and efavirenz, an alternative method or additional contraceptive methods should be used if the regimen is based on any of these. The complete list of drugs which have interactions are available in our local guideline. However, there are some important drug interactions which we are going to discuss over here. Boosted PIs have interaction with the statins, methadone and buprenorphine, and tenofovir. So it is recommended to monitor the renal functions of tenofovir is co-administered with boosted PIs. Efavirenz has effects on amodiaquine, methadone, and nevirapine affects itraconazole and ketoconazole levels. Dolutegravir has effects on metformin, anticonvulsants, and polyvalent ketamines. Also, there are certain antimalarials which have significant drug-drug interactions with the ARV. So, when starting antimalarial therapy, these should be checked. Response to ARV regimen is monitored through clinical examination, immunological findings based on CD4 count, and virological grounds. which is checked with viral load or plasma RNA levels of HIV. So, a patient who is clinically failing is a patient who presents with new or recurrent clinical event indicating severe immunodeficiency after 6 months of starting effective treatment. A patient who is presenting with immunological failure is defined as a patient who has a CD4 count at or below 250 cells per cubic millimeter following clinical failure, or his CD4 count is persistently low, less than 100 in adults and adolescents, less than 200 in children less than 5 years of age, and less than 100 in children who are more than 5 years of age. Patient presenting with the plasma viral load above 1000 copies per ml based on 2 consecutive viral load measurements in a 3-month interval period with adherence support following the first viral load test after at least 6 months of starting new ARV regimen. There is a condition which is known as blip, in which the viral load is up to 1000 but not more than 1000 copies per ml in a previously suppressed patient, followed by subsequent viral loads of less than 50 copies per ml. The condition is temporary and may occur with any acute viral illness. Before labeling a patient of having treatment failure, drug-drug interactions, malnourishment, and non-adherence should be ruled out. What is resistance to ARV or any other drug? By definition, the ability of microorganisms to withstand a drug that once killed them, making drug ineffective against them, is known as resistance. HIV drug resistance is caused by changes in the genetic structure of HIV that affect the ability of medicine to block the replication of this virus. And this we have discussed in detail previously. Mutations are written as an alphabet followed by a number and then another alphabet. And we have taken the example of M184V, which is mutation for lamivudine. So M here means methionine, which was an original protein, and 184 is a number of codon where mutation is in, and B is the valine, which substitutes this methionine. So what happens at codon number 184, methionine is substituted or replaced by valine, and hence the mutation against lamivudine is conferred. But we shall now discuss that if a mutation is reported, what does it mean? Which drug will be resistant in the presence of that mutation, and what will be the impact of that mutation on other ARVs? This is important to understand because with the help of these mutations, we will be able to design the second and third line ARVs. So if M184V is reported as a mutation, it means that lamivudine is resistant. This is basically the main mutation for lamivudine resistance. And however, this resistance is not the bad one. And although it decreases the susceptibility to lamivudine and abacavir, but it has a beneficial effect on zidovudine and tenofovir susceptibility, and it delays the development of TEMS. That is why in second-line regimen, even if lamivudine is found to be resistant, it is continued due to its beneficial effect on other ARVs. Now, if K65R is reported, it means that either tenofovir and abacavir are resistant. This is the signature mutation for tenofovir. Presence of this mutation reduces the susceptibility to both of these drugs. However, it has beneficial effect on zidovudine. However, the effects are less as compared to M184V, and M184V does not delay its development. Now, if Q151 mutations are reported, it means that all NRTIs are resistant. Hence, with the presence of these mutations, NRTIs should not be the part of second or third line regimen. If TAMES mutations are reported, it signifies the resistance to zidovudine, And there are two pathways, TEMS 1 and TEMS 2. TEM 1 has a high level resistance to zidovudine and more NRDI cross resistance on tenofovir and abacavir. Now, if K103N is reported or Y181 are reported, it means that efavirenz and nevirapine or NNRTIs are resistant. And K103N is different from 181 mutation because in the presence of K103N, etravirine is still susceptible. However, if Y181 is present, it means that etravirine is also resistant. In adults and adolescents, including pregnant and lactating females, lamivudine will be continued in second-line ERT. If initial regimen contained tenofovir, then it can be switched either with abacavir or zidovudine, and zidovudine can be switched with tenofovir, and abacavir can be switched with zidovudine. If third drug used was dolutegravir, then atazanavir or lopinavir boosted can be used. And if third drug was efavirenz initial regimen, then dolutegravir or atazanavir can be used. Now, abacavir should not be switched to tenofovir because if abacavir is resistant, then it means that K65R mutation can be present, and this will make tenofovir resistant as well. In some special circumstances where zidovudine cannot be given, dolutegravir with boosted lopinavir can be used if dolutegravir was not used in primary regimen. In patients with hepatitis B virus co-infection who have been exposed to tenofovir as a monotherapy or as a regimen, tenofovir should not be stopped. Lamivudine should also be continued. A regimen can be made like if the patient was on TLD, tenofovir, lamivudine, and dolutegravir, then ACT can be used instead of tenofovir for HIV. However, tenofovir will be continued. Lamivudine will be continued both as an anti-HBV drug, and we have already discussed its beneficial effect, and dolutegravir can be switched with lopinavir boosted. If primary regimen in hepatitis B co-infection patient was based on zidovudine, then tenofovir is preferred over abacavir. If abacavir was used in primary regimen, then tenofovir can be used, and tenofovir would be continued with zidovudine if tenofovir was used as a primary regimen. No. If patient is on rifampicin as well, then double dosage of dolutegravir and lopinavir ritonavir would be administered, and atazanavir would not be given with rifampicin. Designing second-line ART in infants and children is a difficult task, and it depends on which initial regimen was used. Here we can discuss just an example. How can we switch the regimen? Like adults, lamivudine will be continued in the second-line ART, and backbone, if it was made of abacavir, then as zidovudine can be used, or vice versa. Now, if third drug was dolutegravir, then it can be replaced by lopinavir ritonavir or atazanavir ritonavir. If either efavirenz or NVP was used, then dolu or lopinavir ritonavir can replace these drugs. And if lopinavir or ritonavir was used in an initial regimen, then it can switch with dolutegravir. For better understanding, we shall discuss the examples of failing first-line regimen and selecting second-line regimen. Initial regimen is abacavir, lamivudine, and dolutegravir, and child is failing on it. What should be the second-line ART? So, abacavir will be switched with zidovudine, lamivudine will be continued, and dolu can be replaced with any of these drugs. Example 2. Child is failing on ABC or AZT, lamivudine, and lopinavir ritonavir. The second line regimen will be either AZT or ABC, whichever was not used at an initial regimen. Lamivudine again will be continued and lopinavir will be replaced by dolu or raltegravir if this drug is available. Example 3. Child failing on abacavir or zidovudine, lamivudine and efavirenz. Then in this regimen, these two drugs will be switched as above. Lamivudine will be continued and efavirenz will be replaced by dolu or lopinavir, ritonavir or etesonavir. Example 4, child is failing on AZT or ABC backbone with lamivudine and nevirapine. Nevirapine again will be replaced by lopinavir, ritonavir or dolutegravir, and other regimen will be as discussed before. You can refer to the local Pakistani updated guidelines for further explanation and better understanding of these regimen, and it is suggested to go through guideline first before changing a regimen. We have now discussed the dosages in adults and adolescents and children. So, Annexure 5 in Pakistan guidelines on HIV can be referred for the dosages in adults and adolescents. Refer to Annexure 6 for the dosages of ARV in infants, children, and adolescents who are less than 35 kg of weight. Refer to Annexure 14.A for first-line ART regimen for children by weight band, and dosages are given over here, so refer to the guidelines. And the table has been taken from Annexure 14B, and this shows the dosages of ARV when ATT is co-administered according to the weight band. Annexure 14C reflects the optimal pediatric populations to be used when severe symptomatic anemia is present, and the dosages are again according to the weight band. We have already discussed the regimen to be used in these circumstances, but the exact dosage should be seen from that. Annexure 14D shows the dosages to be used when NVP toxicity is observed according to. Designing third-line regimen is a difficult task in Pakistan due to availability of only limited number of ARBs, and by the time third-line regimen is recommended, the patient has already been exposed to many available ARBs. This should ideally be based on resistance testing, and ID experts should be consulted before designing this regimen. Now, the only limited options are available for third-line regimen, and the recommended third-line regimen is with dolutegravir, with darunavir, ritonavir, with 1 to 2 NRTIs. If patient has already been exposed to 2 NRTIs, efavirenz, etesonavir, and lopinavir. In all population groups, this regimen can be used. If the patient is protease inhibitors experienced, then the dosage of darunavir, ritonavir recommended is 600 by 100 BIT. And if the patient is INSTI experienced, then double dosage of dolutegravir is recommended. A take-home message. The main goals of ART are suppression of viral load, restoration of immunity, reduction in HIV-related mortality and morbidity, and prevention of HIV transmission. At first, the confirmation of HIV history taking and clinical examination should be done. Readiness to start ART should be assessed, and counseling regarding adherence and education regarding disease and ART must be performed. Opportunistic infection should be carefully ruled out, especially tuberculosis and cryptococcal meningitis. Pregnancy test should be done in females. Baseline PRT labs include confirmation of HIV, CBC, creatinine, hepatitis B, C serologies, STI screenings, tuberculosis screening, CD4 cell count, and other opportunistic related infections. Backbone of first-line ART in adults is 2 NRTIs and INSTIs, and in children it's 2 NRTIs and protease inhibitors. Major side effects of drugs, pharmacokinetics and pharmacodynamics, and contraindications should be considered when designing the regimen. Monitoring of ART is done before initiating of ARV, at the time of initiating of ARV, and after starting ART. ART should be started on the same day or within 7 days of diagnosis after ruling out opportunistic infections. Response to ART is monitored clinically, immunologically, and virologically. Uh, Dolutegravir is safe in pregnancy and is now recommended as a first-line ART. In hepatitis B and HIV co-infection, preferred regimen should include tenofovir and lamivudine. M184V mutation of lamivudine increases the susceptibility of zidovudine. Second-line ART in adults is designed according to the lysine mutation. Lamivudine is continued due to its positive effect of zidovudine and tenofovir. If person is failing on abacavir-based regimen, they should be switched to tenofovir. Tenofovir is switched with either zidovudine or abacavir, and dolutegravir is switched with protease inhibitor. Efavirenz is switched with dolutegravir or protease inhibitors. Dose of dolutegravir and lopinavir is doubled with rifampicin. Antiretrovirals have significant drug-drug interactions with many drugs, and these should be considered while introducing newer drugs.